All right. Hello again, and welcome to another Down Fracture podcast, a podcast for talking jaws. Per usual, this is Dr. Michael Wasson of Arizona Jaw Surgery here with Dr. Sam Bobek of Seattle Jaw Surgery. And general housekeeping as always, downfracturepodcast at gmail.com. If you would like to email us any episode suggestions, patient cases, insults towards Sam are always appreciated. And we would go from there. Well, today, Sam, we have a guest. You want to tell us a little bit about him?
Yeah, we do. Our discussion today is on improving communication between the surgeon and the orthodontist for jaw surgery cases. And so we brought on an orthodontist who knows a lot about this. So Rooz is here today. Rooz Khosravi is with us. He has a couple of practices. I think Sammamish and Bellevue. Is that right,
Yeah, the
Rooz?
two. Correct. Yeah, two
Uh,
locations.
He's super accomplished. Had finished his ortho residency at the University of Washington. He is it a master's in oral public health and a PhD in bone biology? Is that right?
Correct. Yes, yes. Before the clinical stuff, I did a PhD in bone biology and a master in public health.
He still teaches at the University of Washington. He's got a high-end private practice where he pushes the limit on computer integration to orthodontics. I've been lucky to work with him for a number of years now, and we do some talks together. And Rooz agreed to join us today. So thanks, Rooz. How you doing, man?
Yeah, I appreciate it. No, I was very excited when you told me about this podcast, so I'm excited to be a part of it. And the topic is very important.
Yeah. So, I mean, I think communication, that's like one of the things I think in residency you don't really get as much. And then when you get into practice, it seems very variable based off of the orthodontic residency training. So, what was it like for you in training and communicating?
I think, maybe I'll go a little unique about University of Washington, right? So part of the things that I do at this school, I run the interdisciplinary seminar series, which is on a Wednesday morning. We don't get the oral surgery because with oral surgery, we do it on a Tuesday morning. But on Wednesday morning, you have perio, pros, pedo, ortho sitting on these lectures, talking about cases that they are truly interdisciplinary. And this is one of the things that I always tell the resident. It doesn't matter how competent you are good when you're collectively on the same page. And we've been thinking through a lot of interdisciplinary care and what is the best way to execute the things that you have. And I think some of it drips into how I work with you, Sam, and how I like every orthodontist interact with the surgeons. Just coming from the training that we were trained how to manage interdisciplinary care, maybe we're a little privileged of having that legacy at UW. But what I try to teach the resident is that establish systems that it, your team know it, and you're all on the same page. And the beauty of this, and we get deep into this down the road, these things were always a key in the communication. When you see successful teamwork, they used to sit together and in person over breakfast and after work and discuss all these things. But when you get in the digital world, you don't need to physically be present to do that level. And some would argue even higher level of communication when you harness all these technology that we have in our practices.
Yeah, so Ruse, University of Washington, for people who may not know, has a strong history of excellent orthodontics and orthognathic surgery or jaw surgery. It's a program that Wasson went to as well. So turn out good clinicians. When it comes to the communicating on the resident side, like my experience was very much the patient just comes sees the surgeon. This is my training experience, by the way. They go back to the orthodontist does their thing, then they go back to the surgeon does their thing, and you might have a meeting to discuss some models in there. Is that what you're talking about in terms of the multidisciplinary discussions, or are you speaking more to like those conferences that you have in the academic setting?
I think the way that we have it is still at the school with the, kind of jaw surgery specifically, because they're two different paths, right? For the interdisciplinary, when we do pros, perio, ortho, pedo all together, we build the treatment plan together. When it comes to jaw surgery, I think this is kind of what you experienced. We had the same thing, but because you have the same training in a different clinic, it kind of molds you that direction.
Yeah.
My understanding is that the oral surgeon residents also tried to kind of like get more engaged, plan everything. I know that they present cases together, pre-treatment, post-treatment progress, to try to kind of sync up. And one of the things that you need to know, or at least this is what I experienced over the years of working with you, nothing is going to be perfect in the day one. And as you start working with each other, there's less of, there's a lot of assumption of like, okay, I know how Sam thinks. So around that, I'm going to just, design these communications.
Yeah. And I find that's true. Like I communicate with orthodontists differently depending on how long I've talked with them, just because they're comfortable with me and I'm comfortable with them. But when you're starting out with new referrals or new practice, I like the digital communication a lot just because it helps with patient education, but also like helps with like my education of understanding like what's going to happen with the braces and your understanding what's going to happen, what potentially happen with the surgery, right? And
Yeah.
so, in practice, have you changed in terms of how you communicate? Like, because you have a private practice and you were speaking about the university. What are you doing in private practice?
I think I love that segue because when you're a resident, when you're in academic setting, you're kind of like your front desk, back desk, everywhere. Like you're the one man show which interact with another provider. But when you get out, it's the patient is more involved because the patient come to the academic setting, they're a little bit more receptive. They trust you a little bit more. There's less of involvement in the process. When you do it in the private practice, this is my thought process. This is what we evolved over the course of several years of working with you and other surgeons. There's a communication between the surgeon and an orthodontist. There's a communication with the surgeon and orthodontist with the patient. Like collectively, you're interacting with them. And then you get the administrative team of your practice and the other practice with the patient. So they have to have some understanding of what is going on. And then you get the interaction of the team with the patient over the logistic of like financial, insurance, healing, multiple questions. So I think this is where I put all type of communication, which we try to hone down, train the team, interact, kind of get it really optimized. Because if you can be, excelling in all these four items, then everything is going to be streamlined, right? I can tell you for one of these reasons that I don't want to work with other practices. Not that, where we are in Pacific Northwest, there's so many competent surgeons, so many great surgeons. And when the patient come to me, I tell them that I don't want to work with another surgeon because of this, because not that I don't trust those other surgeons, it's just because these layers needs to be established. It's less about, or maybe it's part about the surgeons and the orthodontist and is more about the team and the patient interaction, all of those.
Yeah, I think the inter office admin team communication and then the surgeon and the orthodontist communication. I mean, in many ways, you just kind of take that sort of thing for granted, right? But it's hard to know what you don't know, right? Like if um, checking on your administrators, how much they're communicating, or a surgeon likes to communicate more and the orthodontist doesn't, or vice versa, right? Like syncing those things up, I think those are the overlooked categories.
Yeah, for sure. It's layers, and you don't need to start doing all of this. I think what you mentioned, things come over time, right? When
Yeah.
you see these people interdisciplinary team that they work really well with each other, remember there are works, there are times, hours, behind that team being smoothly operated. So,
Yeah.
don't rush in to try to optimize all of these. Start with your surgeon interaction, then build up other layers of it.
Let me ask Wasson, what do you think? Communication in terms of your office and your average orthodontist that you're working with. Do you think it's easy? I personally think it's the easiest one is the surgeon to orthodontic communication, and then the surgeon to patient communication. What's your practice like?
Yeah, I think one of the advantages of practices like yours and our scenario, because coming from a practice where we did, a fair amount of orthognathic surgery, but also everything else, it was tough. Like communicating is difficult. You've got so much going on. Your admin team's got, insurance submissions, collecting money. one of the benefits of having a practice now that's pretty exclusive to this stuff is the communication is so much better just simply as a matter of time. And like you're not seeing 15 consults in a day to where, if an orthodontic office calls our office now, my front office administrative team, they know who the patient is, like right off the top of their head, because it's 3, 4 patients a day. And so there's familiarity. It makes all that so much easier coming from that opposite environment. A question I guess I would have for you guys, and you touched a little bit on it, Rooz, would be what are your admin teams doing per se? Because I
Yeah,
feel like most of the communication, Sam, you said was the easiest. I feel like most of it is between myself and the orthodontist, and then myself and the patient, and then I guess what administrative tasks are you guys teams doing with one another to facilitate this and make it easier?
I think I'll put it in like two or three buckets. The one that is like kind of obvious is the logistic, right? I am coming to see you. When am I going to go see Sam? What is going to happen after Sam does the surgery? When am I coming back? When are they removing the TAD? All these like little nuance of, logistical stuff. Then there's the anxiety around surgery, that the TLC, that it has to be there. I mean, last 2 weeks ago, Sam did a surgery on one of our family friend. He has like a mega open bite. I convinced him that you need to do surgery, and he was like worried
Wait,
about it.
hold
So
on. Can
he
I
like,
stop you there? You're friends with those type of people?
yeah. So then,
You got to be more selective with your friends, buddy.
oh, for sure, for sure. Well, I got to change that. And then, so when I talk to him, he's panicking, texting me, and I try to like walk him through the process. So he knew me, so he sent a text directly to me. If
Sure.
the patient that doesn't know me, where are they going to reach out? My team, right? So the
Yeah.
team has to communicate with the patient. So there's this TLC and the constant, hand holding, reassurance. I mean, it's a big deal, right? Jaw
Yeah.
surgery. You and
Absolutely.
I, we think about it as like a walk in the park, but like even the fear of like they're gonna cut my face is a big weight on the patients, right? So those are the other layers of communication that I like to train my team. So then the front desk, when they pick up the phone, they know how to triage those or navigate it or pass it to me. And then there's the insurance. The insurance, the cost, it's a huge things. We generally just pass it to the surgeons and say that, let us know if you can help with anything, but we cannot help you with those aspect. We can help you with the orthodontic care of it, but the surgery and the cost is not our expertise, right? I mean, working
Right.
with the SAM team for a while, we have some sense of it. So we're like, never use the numbers, just give them some ideas and then pass them and reassure them that they're gonna help you to navigate that situation. So three bucket roughly.
Yeah, and I think that the records part of it is an important like
Yeah.
pathway that can be streamlined. Um, so we don't receive a referral, then we're reaching out for records, and then they're sending it our way. It's just like, well, I send for a consult, and I already have a cone beam, so let's just send it their way. Or we need them to take a cone beam, and then we do. Because I like that part, which kind of segues into the next segment of this discussion, which is, I like syncing the planning at the beginning. Planning the surgical plan outside of, hey, this is going to be a mandible or this will be a two jaw. Um, and your planning's more than, oh, can we do this with Invisalign or not? Actually syncing our plans at the beginning and communicating in the in-between step that we get them off to the pre-op ortho, set them up on a recall visit for a visit before surgery, and then we plan surgery. Because in the past, I think my communications with orthodontists were just generally at the beginning and then right before surgery on the 3D plan. But I like our syncing of our plans at the beginning. What do you think about that, Ruz? Has that been helpful or?
I think that's vital, especially when you start working with somebody brand new, right? So
Yeah.
like, I know Michael forever, but if I want to start surgery with Michael, I would like to have my first 10 cases planned from upfront, because then he would realize, what do I think? What kind of occlusion do I want? What do I think about the because orthodontics is similar to surgery. There are so many school of thought, right? you
Absolutely.
know So if you can sync that up front, where I would lean on your expertise, you lean on my expertise, then you don't need to do it all the time. I mean, we do it on complicated cases, like the crazy stuff. An example was that case that you did surgery first. I was panicking when I did my simulation. I was like, Sam, this is not going to work. What do you think? Do we really need to do it? He's like, you're fine. So I know him. I know what he looks at. So when the patient came back with the surgery for his occlusion, he's like freaking sucked down, perfect, ready to go. And she needs probably, I told her, like, your treatment is going to last another 6 more months. And I'm going to this is not a 2 years plan anymore. Right. So I think upfront is a great educational for both parties and like syncing.
Yeah.
I like that a lot. And anything that is complicated, 100%. Right.
So
It's also good for training the patient.
So how are you guys doing that? Because I've always, we all three of us, I know, lecture on these things. And I always, what's the future of jaw surgery? What's new in jaw surgery? And that's what I've always kind of said. I think the future is going to be one software that we can all log into, whether that's the general dentist, the prosthodontist, the periodontist, the oral surgeon, the orthodontist, and we come up with, even if it's asynchronous, as you're saying, like, hey, go do your part and I'll check in and I get a notification when something's changed. Like, we basically come up with a plan in totality, whether it has restorative aspects or not. And we can kind of come up with a final plan in a digital model. And then it doesn't matter who does their part first, second, third. Like, you can almost just say, here's the final result. If I'm doing my step first, what does that mean? And you plan it. Or if I'm doing my step last, but I feel like we're not quite there. There's some ways that you have to jump around that. Sam and I use Dolphin that allows us to export STL files and occlusions and things like that I think make a big difference. All of the clear aligner and some of the other custom bracket softwares allow you to, come up with a plan and show the occlusion. But where do we stand in that? Are you guys aware of more technologies, or do you have a different system in place that makes that less necessary?
I think we're closer to doing that than you think. I mean, I think patients believe us to come up with a master plan at the beginning. I figured that out like in fellowship, early practice, and I just kind of chalked it up to, they don't necessarily know what they don't know. And I mean, the argument against planning in the beginning is that there's still inaccuracy to carrying out the plan, right? So
Sure.
we have the best plan with surgery, the final surgical result could be different. Best plan with orthodontics, final orthodontic plan to be different. And so what we're talking about isn't necessarily starting with surgery or starting with ortho. It's synchronizing the overall surgical plan and the orthodontist plan at the beginning, so they're roughly the same. I think you still need to replan, but the communicating in the software, at least on my side, seems pretty good. Rooz, what about yours?
Yeah, no, I agree. I mean, I think there's a practical way and there's the ideal way, right? Ideally, as Michael said, I love the idea of one software we can all log in, but that just doesn't exist, right?
No, yeah.
The way that I look at it, jaw surgery has to plan starting about the bone. Like, I look at the bone, where I want to put the bone, based on the occlusion, based on the aesthetic, based on the function, then look at the occlusion. Then my job as an orthodontist is to make that occlusion right post-surgery the most best stable occlusion for the surgeon, so they can execute it, they can get it there, and then they can carry the rest. That's literally every case that I have. This is the sequence of the relay race. Where do I need to hand you the baton? You're going to give it back to me. And that is the key. When you plan in advance, you see all these little issues. Like, for example, there's one thing on the screen. If you ever get to see the video, there is like one, premature contacts. How can I get that away so then you get a better settled bite? That's make it the surgeons easier to move the jaw. So I think what we have right now is fine. Is not ideal. Let's say Sam uses Dolphin, get everything dialed down. Sometimes even send me the STL. I put in my software. And the reason that I don't think that this is going to change a lot, remember, I work with a lot of companies on software development and product. You need to have a huge demand for these software to get created.
Exactly.
Jaw surgery is a small, tiny world.
This is
The
the problem.
orthodontists are a fraction of them they doing. So nobody's going to put money on this, right? Unless
Right.
we decided to fund them, from like just our day-to-day life. So, but what we have, it's reasonable. It's reasonable to still deliver a good care. I
So
think learning these, like what Sam did, like brought all of these in-house. That's a huge improvement.
yep.
Yeah, because
So
there's barriers on the surgeon side to making this happen, and then on the orthodontic side, um, I think it's Rooz, do you have that slide that you had the previous best workups that you could do? Um, and this wasn't that long
Uh,
ago. The one with all the waxed up teeth and then the
oh yeah, yeah, yeah,
articulated
yeah.
models and
I mean,
everything.
this is not a surgical case. This is more like an interdisciplinary, but it shows you what we used to do these things, right? You do
But
all
yeah,
these workup and you move it around.
this is giving me PTSD just looking at
Yeah,
this.
yeah,
yeah.
there's a slide up. It's got, individually segmented teeth on stone models that are remounted in wax, and then there's
Mhm.
crowns that are then waxed on those stone models.
Yeah.
I mean, there's an articulator, clinical pictures, and two-dimensional X-rays. I mean, I think a lot of the stuff that we have now versus 15 years ago in terms of surgery and orthodontics is great. It's great. I mean,
So great.
in-house CT scanning, in-house optical scanning. You can do trays, you can print your own stuff. The next step with communicating, I think, is in tying the plans together is kind of what we're talking about. And I think that at least on the surgeon side, for me, that made the big difference is being able to plan things in my office. So I didn't need to ship things off to a planning company. Because honestly, it's the cost of the planning company. You send things to the
Mhm.
planning company, it's another whatever, $1,500, whatever they charge you now. And having the patient have two of those costs was difficult. Ruse, on your side, what kind of barriers do you think are on the orthodontic side for doing it?
I mean, the problem with orthodontic side is that the software that we have for orthodontic treatment planning, they don't have jaw surgery built into them, right? So you
Yeah,
just guess off of the occlusion. And to me, that's just a silly way of doing this stuff, right? I think the plan for surgery should start with the bone. Where the bones are going to go, then look at the occlusion, then adjust the dentition to that occlusion, right? When you start doing it, then you can imagine some of these things. But like, having a surgeon that does these treatment planning is a wild, kind of things that you want to have. And I would say, like, for the younger people that they want to get into this, just buy Dolphin and start playing with it. Yes, ideally you want to have somebody to do it for you, but it's not that hard, right? And the more you do it, the easier it gets.
I would
Yeah.
agree.
But what you're saying, Ruse, and I want to make sure I'm understanding you, but I think some of the audience of our massive following who are listening to this, what you're saying almost seems backwards than traditional thought, if I'm understanding you correctly, because traditional thought and the reason for pre-surgical orthodontics has always been, level align, coordinate the teeth, put the teeth in the ideal position within the bone, irrespective of the arch. So put the maxillary teeth in the ideal position, put the mandibular teeth in the ideal position, and then the surgery is what places things to then fit that occlusion, and then we take into account, of course, aesthetics and other things. But are you saying that with this new technology, you feel that reverses that traditional kind of treatment protocol, or are you saying something different?
I mean, I will let Sam to answer that a little bit, but this is how I look at it. I like to start with the bone, right? I mean, it doesn't mean that you're not going to level the arches. It doesn't mean that you're going to place the bone. Those are all fundamentals that's going to stay, right?
Okay.
Keeping the teeth in the right spot, leveling the arches, getting everything in a good spot. But I want to start from the bone, right? Where can I place these jaws that they are functionally, aesthetically good? Then I can tweak with my occlusion, right? And remember, leveling perfectly is not always like the best solution for a surgical case, right? I mean, we have cases that we do three-piece lower because you have to torque the lower anterior in to get a good occlusion, right? Is it aesthetically perfect? Maybe not, right? But it gives us a better functional occlusion, right?
Did
So
you just said three-piece lower? Do you mean like a subapical? Is that what you're talking about to
I
adjust the
think
lower
so.
incisor position? Is that what you're talking about?
Sam can answer that, but yes.
Yeah, just segmental mandibular surgery, like
Okay.
either
Let me show
bilateral
you a
body
case.
cuts or subapical, like the
Here's an
segmental mandibular
example.
surgery. I don't think Wasson's ready for that picture right there.
Yeah, so this
He
is
doesn't even like
this is a
steps in the
little.
mandible. He was harassing me
You
about that, I
you
think.
do love steps, man.
Steps
You
are
love
the best.
steps.
There's a class 3 case and it's got bilateral body steps along with the
And it's
sagittal.
like this patient has a huge amount of tooth size discrepancy, strong marginal ridges, very, very thick. How can you get this occlusion to fit? Keeping all this stuff, like the teeth are going to be inside the bone. There's not a huge amount of soft tissue in here to play with. So I don't necessarily believe that we need to level completely. We don't need to just, fundamentals of ortho within the boundaries of the bone, within the boundaries of jaw surgery that we can do.
Because we can come up with creative surgical plans to merge kind of the orthodontic outcome to the aesthetic and functional purposes of the surgery. But the idea of like communicating ahead of time. So
Yes.
if I haven't spelled out, what I'm getting at is just starting with your virtual surgical plan. So you see him for a consult, you get the STL and DICOM, draw up the plan, and then send the STL for the proposed final result to your orthodontist. And we could even meet to discuss that, but then they just get those teeth to fit, which is obviously not how the jaws are aligned yet, but it allows true decompensation, right? Like
Yeah.
decompensate towards a goal rather than try the best, and we're going to generally do some jaw surgery, and then I'll just come up with some fancy game plan right before surgery.
Yeah,
And this,
I really like that, but I think maybe this speaks to what I struggle with, and maybe the orthodontists that I work with struggle with me as well. I don't want to make this a one-way street. Is we've kind of said it a few times, but we don't. Different training programs do different things. Different geographical areas have a tendency to do things, and that's where I struggle setting up these plans as a preliminary plan, like you guys are proposing, because there are some orthodontists I've worked with in the past that I feel like, hey, I as the surgeon am probably going to have to do most of the work here. Their comfort level, maybe more than their ability, is just maybe limited. And I would also throw in there that they don't know me as well. And they may have those same reservations about me. They may not be aware of certain variables. Like, I mean, let's be honest here. How many orthodontists are going to be familiar with the case you guys just showed? Oh, yeah, we can do bilateral mandibular body osteotomies to help this. No orthodontist is going to come to me and propose that. They don't
well,
know.
it doesn't happen the day one, right? The key to
Exactly.
know is that it takes time, right? You start simple, you build it up. Did I do all these crazy cases with Sam from day one? No. When I see that I can get that occlusion to fit, going through the treatment planning with him, then I bring it to him. It's like,
Well,
propose some ideas that we need to go.
yeah, that's where I guess I'm kind of getting at, because I think what you guys are proposing in the way of your communication, and what I've tried to do too with Dolphin, but I haven't achieved this level yet, and this is kind of awesome to see. But where I struggle is, one, not wanting to propose something that someone's not comfortable with. Two, not wanting to insult someone either. Like, I mean, I worry about that in the sense of, because I'm worried about proposing something and that being either insulting or more complicated than what they're comfortable or willing to deal with. And I guess you don't find that out unless you try. But there are some cases where I would say, hey, look, I think this needs to be segmental surgery, and I've got to try to make the teeth fit together really well. There's other cases where maybe I'm working with an orthodontist and I feel like, okay, they can probably handle a lot of that on their own, and I don't have to do a little less. And so I think that's one of the benefits of what you guys are showing here and having these planning sessions ahead of time, is both parties can look at it and maybe better understand each other's capabilities. Because when you presume certain things, I think that's where you get into trouble. Yeah, I presume that if I set it up this way, the surgeon can finish it, and vice versa. And so I think this is pretty cool. But for those of us who aren't as familiar with it, can you guys almost kind of do a step by step of your process? So it sounded like you started it, Sam. Like someone gets records, STL files, cone beam, merges it into Dolphin. Are you guys having a meeting at that point? Or I guess when you first started, were you having the meeting at that point and then coming to an agreement, and you were exporting STL files to Rooz, who was then taking those STL files from the planned surgical position, putting them into some form of orthodontic software to then where he can see how he needs to plan it out? Or I guess maybe take it a more step-by-step approach for people who are less familiar with it.
Well, so I would say the first things that you were talking about had to do with kind of the stressors of, what the surgeon's bringing and what the orthodontist is bringing to the situation, that they're unfamiliar with each other and what kind of training they have, and they just view the problem through different lens and syncing those lens up. Um, so from my side of things, getting the data and more specifying the plan, right? So that if I say a sagittal split osteotomy or I say a two jaw, when I say a two jaw, I mean, I mean a broad number of procedures. Like I'm pretty comfortable with whatever segment of whatever. And it's basically upper and lower jaw surgery to optimize the 3D position of the upper and lower arch, upper and lower jaws. And so, but if I'm working with someone new, if I draw all that up, right? So if I get it on a dolphin plan, I can meet with the orthodontist. For other orthodontists I work with other than Rooz, I've videotaped those, just videotape me moving the bones around and then upload them the 3D plan. They have clin checks that they send to me, right? And so it's like, hey, if I change the angulation on these teeth or if I do some PAOO, is that going to set us up for that to be good? And so the communication can be on a web meeting together, or it can be kind of the asynchronous communication. What I like of the step of having a surgical plan, and let's say if we were going to do surgery first, I would leave them with 5 or 6 millimeters over jet on a class 3 situation, and then sending the STL to Rooz. Then Rooz can design his aligners or lingual braces or whatever he's going to be doing to then set it up.
So
What do
he's
you think?
so he just to be clear, you're using that surgical plan to both make a determination to the feasibility or desirability of surgery first, or you're just helping him as the orthodontist have a better understanding of the end position, and he's starting his pre-surgical orthodontics based off of that end goal.
Yeah, I think it's less to make the case for surgery first. It's more like, because when I reference this, it's virtual surgery first. It isn't that you're doing the surgery first. You're just in the computer, you're correcting the bones. And then it's helping um, direct the pre-surgical orthodontics, not direct, helping with additional information. Would you say, Ruse, for the
Yeah,
setup?
so there's again like the ideal world and the practical, right? When a patient come for a jaw surgery, we collect CBCT, STL models, the optical scan. Ideally, I push Sam on this all the time. Ideally, I don't want my patient even see the surgeon, right? Because we can manage them, right? To some degree. I like this to go to the surgeon. Surgeon does the setup based on function and aesthetic of bone first, send it back to me. I look at it, and then I can use those STL files to do my treatment simulation. I'm not going to try to do the actual work, but I'm simulating, right? If Sam gives me this bite, what do I need to do to finish it? That's one question that I'm going to try to answer it. The more important, what do I have to do to give him that bite? Because the bites that he's sending me is where he's going to try to do during the surgery. And if that bite is in a good spot, the likelihood of him getting that surgery done is higher. And it's just kind of like a vicious, or it's a positive reinforcement that if I do my job and he does his job, then the surgery is going to be more successful. Then I don't need a lot of time to try to get the patient to the end, right? So
Sure.
I'm not saying that this is going to happen in every single case. If I want to have an ortho surgery office that is going to run like that, I want to have the patient come in one time, collect the records, create a simulation, virtual meeting with the patient, discuss all of those. Ortho start, you see the surgeon 3 months before the surgery, and then carry on, right? That's the ideal work. Does it
So,
happen all the time? No.
so you're saying they're not even seeing Sam like for a
They
consultation?
They do
Okay.
because they want to talk to the surgeon. I don't
Right. I
like
would
that.
think so.
I would hope that we can eliminate that, because to me, that's an appointment that can be virtually done. But the emotional, the interaction, the physical interaction, there are things that you can't just,
Yeah, I mean,
ignore.
on the surgeon side, that's a pretty good, like the first appointment's a good appointment to
I
kind
think
of
so.
develop rapport.
Yeah,
Yeah.
agreed. I think rapport is huge there. Trust is huge there. Getting to know the office so that it's one less scary thing, anxiety causing thing.
Yeah.
Yeah. Yeah, Ruse, you're way off here. We don't want to get rid of that.
No, but trust me, I build the patient that would trust anybody that I send them to, right? So, and I think that goes along with the discussion of if the offices, if the providers are all synced in, if the transfer of trust is very easy. I'm not saying to eliminate that appointment. I think it's
Yeah.
unnecessary from a logical perspective, but I don't want them to even doubt the surgeon. That's why I tell them that I only work with one surgeon.
Right.
Well,
Yeah, but I mean in 2025, Ruse, what you're essentially saying to people like Sam and I is if anything goes wrong, you want them to write a negative review on our website and not yours.
There you go.
Because you have rapport and we don't.
That's what they do. And then I have to manage them for those negative reviews. The
yeah,
We
next
no,
know
I mean,
your true motives here, Ruse.
when it comes to extra work, is extra work on the surgeon side? I think it's helpful on the ortho side. Am I
Sure.
wrong on that? Is it more work on your side, Ruse?
To do
Like
what?
adding in this initial plan that we're
Yes,
talking about?
because it slow down the process of starting. I mean, if
It
you
slows it
if
down.
you if you get that dialed down and you can have it to me before meeting the patient, then I can convince them that, like, this is the, because you get a consultation. Sometimes it takes 2 months, 3 months to get them to commit to this, right?
Yeah.
I am not against it. I think it's completely fine. It's a big decision for everybody's life, right? But I always think about how can we do things efficiently to
Yeah.
reduce the time,
I mean,
right?
I'm glad you brought that up. I bet you there would be a way, which I haven't really focused on this, which now that I'm speaking, I feel like I should have, to get you these plans before you see them after I see them.
That
You know
would
what I
be the
mean?
wild thing. Yeah.
Like if I
Yeah.
tomorrow I'll see one of your patients, let's say, and then you have a follow-up with them in a few weeks. Having
Yeah.
our plan in your computer when before you see him again would be pretty sweet.
100%. Because that reassured them again how sync we are. A
Yeah.
piece of paper with 3 pages of, like, this is what I'm going to do, which is the usual reports that you guys are sending, is important, right? But how much that can help me to convince a patient that, okay, this is our plan, this is what we're going to go. And we also want to be careful about some of these things. Sometimes over sharing the plan with the patient can backlash, right? So you want to keep that balance, right?
Yeah.
Um, some of these simulation can bite you back. So I don't want to, like, propose the notion that, you just go all in, share everything with the patient. I think you need to be selective and
Yeah.
simplify it, because it can backlash as well.
And Ruz, I think but on the surgeon side, a lot of the decision on what you're doing with a single jaw or two jaw is very much clinical decision making. You're talking with the family about their comfort, or the patient, the family about their comfort with risk, cost,
Yeah.
how much you're getting out of doing two jaw versus one, those sort of things.
Yeah.
And so, getting you that information timely sounds like a nice way.
It
You can probably
helps. Yeah.
tell Wasson we're still kind of fine tuning this whole thing because
Yeah.
I don't know how long
I
we've
mean,
been doing
I
this
love
thing.
it. I think it's great. I mean, I've tried to implement some of these things and some of my shortcomings are just, as I've said, like, I don't want to step on toes because you are in a way, again, not every orthodontist and not every surgeon is going to be receptive to changing their systems. Like if I come in and I'm proposing, hey, I'll work this up, let's have a web meeting, or I'm going to send you some stuff and I want some feedback. Like they may be like, oh, I don't want to work with this guy. Like this is more work on my part. Like what I've been doing for 20 years has been working. So I guess let me phrase the question to you guys that way. While everything seems more ideal to have this plan from the beginning, do you feel like, having done this for a little while now, do you feel like it's tangibly improving your outcomes? And if so, in what ways?
Not for every cases. Like, after you're working with somebody for 4 or 5 years. In the beginning, for the first year, if you do that, it's going to majorly impact how you get synced with the other provider because you're sharing your thought process visually, and then you understand, you explain your rationale and understand the response to those rationales. And one thing that I want to say, if you propose this notion to 10 surgeons and 10 orthodontists, and five of them they say that I don't want to do it, just work with those five that you can and they want to do it. And I promise you that if you stay on it, the other five will come and chase you down to do the same thing because there's a learning curve. There's a dip that you have to go through. And when you go through that coming out, things will get easier. Do we need to do for every single cases? No, because we've done it enough. We've done all iteration variation of it. So you don't really need it unless it's a very complicated case. I generally text Sam, it's like, Sam, can we do the simulation? Because I want to make sure that I understand what your plan is. Sometimes I'm just panicking for no reason. Sometimes he texts me and he's like, okay, what are you doing for this? Right. So I think that the pre-simulation plan is essential to develop that collaboration for the first year or two at a cost of excessive amount of work that they may or may not be good, but
So
you just go through the path.
what do you think, Sam? Do you think, are you seeing tangible benefits or other benefits to this?
Well, yeah, because I mean, do I think it influences the final surgical result in a better way? I mean, I don't really think it does, largely because I feel like I can sort out most situations surgically anyway. Um, but in terms of the beginning, working with people and syncing up our communication, it helps like I don't know, it helps so much because I mean, you work with people like you're saying, they've been practicing 20, 30 years. They're super comfortable with surgery and the setup, and it's like I know what they're talking about. They're like, are you gonna do a SAG? And yeah, that's the game plan, and that's experience. We're gonna be comforted at the beginning. But I think coming out of residency on the surgery side, if all you've done is 3D planning, you don't really know too much about the orthodontic setup, which I believe to be absolutely the truth when it comes to most oral surgery residencies. Um, and and on the flip side of that, a new orthodontist coming out and you learn about orthodontic communication and surgeon communication in a certain way, like improving that at the beginning is right. Because I mean, I just think we're past the time of bringing models over to Rooz's office in person and him and I looking at an articulator, meeting up on a web meeting because we all have a short amount of time and looking at the 3D plan seems to be a way better way to communicate.
Yeah, agreed. Agreed.
So I I think it's really developing new relationships and then also just comfort level with stuff. So I would have totally been into this right out of fellowship, but I'm a little nerdy on this stuff, so you should try it out, Wasson.
Yeah, I mean, I'm trying. I mean, I'm definitely, for most patients, I put it into a pre-treatment simulation of my own, and then similar to you, I send usually a video to the orthodontist when applicable, and also the patient. Like, hey, I think it's good for the patients to see, and I'm very clear, like, hey, this doesn't include any orthodontics. This is not going to be exact, but they're always asking, how's my face going to change and what aesthetic changes are there? And I think there's huge value in that because as much as you try to explain it to them, they don't always understand. And I think for understanding and case acceptance, it's huge to just be able to do this in your office, record a 3-minute video, and send it to the patient as well. I think there's value in that.
Yeah,
So,
no, I agree. I
Yeah.
think patient education is great. But again, I think you still have to plan it again, right? So if they go off to orthodontics, it's not, you still might need a 4-piece mandible, 6-piece maxilla.
you need
I'm,
to
And
calm
I
down, man.
I'm just kidding.
You need to
and
calm
I
down with
No
your
one needs the old 10
your
piece.
your bilateral body osteotomies. Like there was no need for that, man.
Dude, I didn't even want
it's
to
a
tell you how
replacement for
awesome that was. That
IPR.
was useful for very good reason, by the way. Uh,
Yeah, for those of you who don't know what we're talking about, there was a video component to this recording. If you want to go to YouTube or I guess Spotify and watch the video, the absolute unnecessary shenanigans these two were putting together here is it's quite the spectacle. It's like carnival level jaw surgery and orthodontics
Bruce,
here.
what other cases you got in there? Rooz got brought some slides. It was so nice
I
of him.
got some. Let me see what else we have.
I mean, you
This
do
is
realize
just
just because
this
there's
is just
bone
a
there, you don't
lineup.
have to cut it, right? Like,
Yeah, this is
All
like
right, is this a
asymmetry
little bit
with
more normal? Here you go.
normal asymmetry with open bite.
Segmental LaForte BSSO open bite
Yeah.
genial.
there you go. Now you're talking reasonable jaw surgery here.
Yeah. Let me see what else do we have. And this is another one.
So
Open bite
Ruse, I
lingual.
mean, we're getting a little low on time here. Um, but I want to understand better what val could you be specific? And if you can't, or if I'm just not understanding it because I'm not smart enough, but can you tell me when we're looking at this, what are you taking from this that you feel is of value beyond just being able to be on the same page with the surgeon and when you speak to the patient, we're all speaking the same language. Are you taking orthodontic value from that plan?
Yes, 100%. So I think, the sooner that you do this, the sooner I know where is my goal pre-surgery, right? What do I need to create for Sam so he can deliver this, right? That's step one. The
Okay.
other thing is that, okay, so this is my simulated, and you kind of alluded to it. None of these are absolute. Like we shoot for it. We might get within the ballpark of 5 to 10%, and I'm happy with that, right? When
Right.
it goes past that, then it's a problem, right? I mean, we did this case, it's a cleft case, and it's such a complicated case. I was just planning it post surgery. Everything is great. The back, there's a big open bite, but I'm like, it's fine. Like, I mean, we correct the jaws in three plane of a space with multiple challenges, right? So when I look at this, I think there are two things comes out of it. The sooner that you do it, the better that I know when I'm ready for surgery, so I can be more efficient with my time, 9 months, 12 months, whatever. And then this is what I have in my head when the patient comes back 4 weeks later post surgery. I look at it as like, okay, this is a great occlusion. I can touch it. I can get it to the touchdown, right? Very easy to kind of deliver it. And I think that what I want to say, maybe as a surgeon who's trying to get into this whole thing, and you assume that the orthodontists are not receptive, which I agree with that to some degree, especially people that are very seasoned. But remember, there's equal number of orthodontists that they're thinking like you, that they're about to start. They want to do this because there's not a lot of orthodontists want to do jaw surgery. I can tell you that. They love to have Invisalign class 1 and just not deal with this. There's a level of complexity with this care. If you find the right partner that is willing to go through the journey with you, you can make it rain. Like these cases, the impact that you have in the life of these people is invaluable. It's such a big impact that I can't do anything that is remotely close to this work, for patients with issues, asymmetry, sleep issue, like all sort of things that you have. And I know there's a lot of push these days in ortho world with like MARPI or these herodontics crazy nonsense that people do. I just stay away from it. Like good old fashioned surgery, when you do it right, you have predictable outcome with less risk. Somehow we managed to move away from this and we put a label, a tag on it. This is complicated, it costs a lot of money. No, I think if you do it right, it shouldn't cost crazy money. You don't put the patient in situation where it's not reversible, because I have a patient that 2 weeks ago was in here, had MARPI, had all the shit that they did, and then now he has to go through the surgery. Why are
Yeah,
we
I'm
doing
glad, I'm
this?
glad you
Right?
s- I'm glad you said that because I feel like if Samurai were to say something like that about Marpy, like we would get so many angry emails.
No.
But as an orthodontist, when you say it, it just brings me such joy. How about you, Sam?
Well, yeah, I mean, I get the philosophy of trying to avoid surgery. Like staying away from jaw surgery makes a lot of sense, but there's some situations where um jaw surgery just seems like the right approach.
Yeah.
And talking to people who kind of do this sort of thing, I'm just of the opinion frequently, if you need jaw surgery, it's the least invasive approach because prolonged
Yeah.
orthodontics is not the best. Multiple
Yeah.
surgeries is not the best. And nothing's 100%, but I don't think expanding upper jaws in every human with screws in the roof of the mouth, that like that that just doesn't speak to, I think, what we've experienced in terms of anatomy. For some people, it definitely works, but for everybody,
Yeah, and
Yeah,
it has its own place, right? It has its
yeah,
own
absolutely.
place
yep.
when you
It's a
for
tool
the
in the
right patient,
toolkit. Yep.
yes, for the right patient is great, but like not for everybody under the sun. You see patients that they have AP problem, transverse problem, vertical problem, and you want to solve it with MRP. Like, how the heck do you think that this is going to pan out?
Yeah.
That, as Sam and I are fond of saying, that dog doesn't always hunt,
There we
right?
go. We
Yeah.
got one in. You know, it's been taking to the end of the episode for you to throw out your old man Southern sayings. So
Well, it confuses you a lot of times, and you get the deer in the headlight looks, and then it
catches me
throws the
off guard.
whole recording off.
I think you know, if you threw one at the beginning again, I might be ready for it now.
Yeah, I've softened you up a little bit. All
We'll
right.
try it now.
What's is there a take home message here? I mean, I know we need to wind up here. I mean, I think everyone, when you generically say it, they would all agree, oh, of course, improving communication is better and all this stuff. But what's the take home point here?
My 2 cents is that start small, give it time, work toward it. Nothing is going to happen in the first year, maybe even 2 years. But if you find your right partner when you start working on it, it only going to get better. But it's over time, right? You both need to learn from each other. Your team needs to learn from each other. You will learn how to communicate with the patient, right? These things are not like a switch that you flip it up and everything is going to be rosy tomorrow.
Yeah.
And I think for a lot of practices, particularly new practices, it's all digital anyway. You're taking STLs, DICOMs, you know, you're setting up digital ortho plan, you're setting up a digital surgical plan. I think most people are closer to doing this than you would think. I really think the main hurdle on the surgery side is just getting to plan it in the office right at the beginning and then just reaching out to communicate. So I don't think it's that far off in the future as you would expect. I think most people who have an all digital practice and they're all digital referring offices, it's just a matter of asking, you think it'd be all that worthwhile in this case? So,
Yeah. I mean, I think some of this is my own. When I say that some people aren't receptive to it, to be clear, I think some of that is just my own hesitancy. I don't necessarily, I think you guys are probably right. Most practices are probably close to all digital at this point. And so maybe I just need to be better at, hey, here's what I can offer. Can we meet virtually for 5 minutes and let me just show you? Maybe that would go a long way. But all right. Well, uh, anything else you guys want to add, or do you want to close this out?
I don't know. I think my other nugget that I would throw out there, Rooz, is that Calendly thing useful or no
I think it's good if you
for your
have a
staff?
big volume, right? So the one way that you can do, I think what Sam is referring to is to have a calendar where you have a set amount of time that your team or your team, somebody in your team, another provider can just log in and book an appointment.
The
I think I do that in my day-to-day life. Like there's a specific time in my schedule that is open and you could go book an appointment. The way that I do it, Sam, I text him, right? But ideally, if you're not into that level of relationship, I think it's a great idea for you to set up a calendar as a surgeon. Like, these are the 5 slots in my week that I'm open to review these virtual setup with you, talk about the cases. It's like an office hour, basically, right? That you open up to your referral and say that, have any question, book it up. And you could do it on Google Workspace. You can do Calendly. There's so many of them.
because I think the admin to admin communication is that. Because I mean, if the two offices need to meet, just set up the appointment. And that way it's on both of our schedules and then we can touch base. So we aren't like, you're not harassing a new referral or you know what I mean? Like
Yeah.
Yeah.
stepping on their toes. I think if you just have a system in place in your office where, the admin team at your office knows your schedule and sets you up and they can send the virtual link already to the other team. I mean, I started the Calendly thing just for that reason. It seems to be super useful because it just shows up on my schedule. So I can be a little bit more hands off. So if Ruse says, hey, send over this patient, I want to see the workup, then my staff just knows to do it.
Any
Yeah.
any barrier that you can remove in the communication is the way to go, whatever it is. If you create a slot for your, referral to work with you, perfect. If you want to give them your cell phone and if you're comfortable with that, that's also fine, right?
Yeah, totally.
Yeah. I guess
All
it's
right.
like they say, a stitch in time is worth nine.
Hmm.
I don't even know what that means. Stitch in time. I'm gonna have to Google it. I wasn't
Figure
ready
it out.
for back to back almost old man sayings.
Yeah.
I'm
I
gonna.
mean,
I will just shake my head. That sounds appropriate
yeah.
usage.
Yeah, why not?
All right.
No one knows what it means. They can't say it's wrong.
There
Well,
you go.
thanks, Ruse, for coming on, and thanks, Sam.
Absolutely.
Again, as always, downfracturepodcast at gmail.com. Feel free to send us whatever you'd like. Well, I guess that was another Down Fracture podcast. Thanks again, guys, and see you next week.
Thank
Thanks. See
you.
you.